All right, now let me discuss today about desensitization. And why is that important? We, as sleep techs, we have a few major roles. We're not buttonologists. You don't just press the button to start a study, to end study, and then you annotate a few. Maybe you can create a report, or you just go home, okay? We have a lot of heavier responsibility. And desensitization is one of the major skills that we have while the patient is in the lab. Agree? You can disagree. However, desensitization is a skill that we can also apply when the patient leaves the lab, because the patients will eventually get their machines and then they'll start to use it. Okay, whether it's CPAP, APAP, what have you. Then they usually will have issues. The main responsible group in addressing these patient issues is the DME, or the Durable Medical Equipment Provider. In other countries, they call them distributors. So the distributors, or the DME, connect with the patient because they give them the devices, their masks, their tubings, accessories, etc. They're also in charge of resupplying. The other major role of a DME is to ensure that the patient is compliant, meaning to say that they will be using their machines appropriately. So they have to discuss and educate the patient, make them familiar with the machine itself, make the patient understand how to maintain the machine, proper maintenance, home care wise, because it's different when you maintain your machines in the sleep lab versus when you maintain a home care device. So it's higher level disinfection in the sleep lab, but at home, they can get away with lesser level of disinfection, not sterilization. But the other major part that a DME does is that they help desensitize the patient with their issues using their PAP machines. Now, desensitization is used in the sleep lab. How and why, right? For example, when you get an order, it's not always diagnostic. You have a split night order, you have a full titration order, and that titration can vary. It could be CPAP, CPAP to bilevel. It could be CPAP to bilevel ST. It could be CPAP to ASV. It could be purely ASV. It could be purely volume assured pressure support titration. Or it could also be an oxygen O2 titration night. Going back to desensitization, when the patients come in the sleep lab for either a titration night or treatment, or they are in for a split night, we have to have the skills to desensitize the patient. So what do we desensitize them from or with? Okay. So one is because the patients will come in whether they don't know anything at all, anything about PAP therapy, or they have gone through YouTube or online searching, maybe some TikTok patients making fun of their PAP machines. So we don't know the level of understanding that they have and whether their understanding of PAP therapy is correct or not correct, because there's also many other options for therapy for sleep apnea, namely oral appliance or mandibular repositioning device or mandibular advancement device. They also have external EPAP. External EPAP is when you place a gadget such as the Bongo RX. Anybody heard of Bongo RX?
It sounds like a percussive instrument.
That's right. All right. Can you see my screen? This is the Bongo RX. So this also requires some desensitization. I've used this gadget when I was traveling. So if you're looking at the screen, this is the Bongo RX. This is considered a nasal EPAP. So EPAP meaning to say it gives positive airway pressure. But how? It doesn't have a motor, right? However, when you look at this device, you will see that there is here. This device has openings, and the openings here, it actually has valves. So this is an option for primary snoring, mild to moderate sleep apnea. This device, when the patient inhales, the valves are open so they can easily inhale. But when they exhale, the valves close. When they close, it creates a positive pressure based on the patient's exhalation. Okay, so that exhalation now becomes the positive pressure to help open up or splint the upper airway. So let's go to PAP machines. Now, what's the main problem for patients when they first experience PAP therapy based on your experience with your patient interactions? They're drowning. So drowning because of the volume of air, correct?
Yes, even if it's at 4 or 5, they feel like they're drowning.
So that is because of the too much flow of air. So what they're feeling is the flow of air. And not just the flow, but now with pressure. A flow can be very minimal. If it's just half a centimeter water pressure, you barely feel it. Okay, it might feel like a little pulse. Okay, but 1 centimeter to 2 centimeters, up to 4 centimeters is our minimum, correct? CPAP, we have a minimum of 4 centimeters water pressure. And for other people, that's not even enough. And when I look at the patient's chart and I see patient is 25-year-old, BMI is maybe 20, 25, so not big, but small, but they might have some obstructive events, low AHI. So I would assume that this patient is even harder to get used to the machine versus somebody with severe apnea, right? I was talking to some of the students yesterday and I asked, what was your highest AHI that you've ever seen or scored? And some of them mentioned 140, 130. I've taken care of a patient. I didn't score it, but I did the VAPS titration for this patient with an AHI of 203. The funny thing is the pressure was not a problem for him. The patient was actually sitting on his remote wheelchair. He came in with the remote wheelchair and he slept on it because he was also paralyzed. He's also not comfortable laying down. He said at home, he sleeps like that. He wakes up and then he moves around. But his head was like cone shaped. His neck was about 22, 23 inches. It was pretty big.
Wow.
Neck. But his head was, and so he's very big. So his cheek was fat and his head was like cone shaped. My problem was not the pressure. My problem was the mass sliding upwards. As I increase pressure, I tighten the strap, it still slides. So I ended up putting a chin strap. I even attached additional Velcro for the chin strap and the mask to hold it down. It was still riding up. I got well over 25 centimeters water pressure on the IPAP. Very high pressure. So he went from over 200 of HI down to, guess what? I had REM rebound. Oh man, that's impossible. I got him down to 80 something.
Oh, okay. Wow.
He was remming. He was just remming. He will only wake up because the mask now starts to leak more because the mask, I had him on full face and it starts to ride up. So when it rides up, it starts to leak here. Then he wakes up, I go back in there, I pull it down and I actually taped it around his face. I was in his room so many times just trying to keep the mask down because of his cone-shaped head and big neck. Even if you tighten, it will still ride up. And I had the chin strap and I added tape.
So sorry, it's a little bit, I guess, maybe off topic, but it's kind of about desensitization. There's so many syllables. But so basically, my sister had a patient that I guess she was saying that it's uncomfortable and the mask is leaking and everything, but our data shows that it's not leaking. That's first. Second of all, she was telling her that we have this issue sometimes where the doctors in the clinic show the patients the masks and the patient finds a mask that's comfortable to them in the clinic from just trying it on. When it comes to actually carrying out the study, instead of theory, when it comes to practice, it doesn't work. So we try to get them onto a full face because they're mouth breathing.
Mhm.
And she was saying that, oh no, it doesn't fit. The doctor told me that the nasal is the best thing for me and all these things. And she didn't want to go to a full taste, not because she has any issues with it, but I guess it was just all in the head. She was saying that the doctor told me the nasal is best, so I want to stick with the nasal. And then as soon as we put it on, 10 minutes later, she falls asleep and then she starts mouth breathing. So obviously all the pressure escapes from the mouth.
Yes. Unfortunately, it's because when they go to the clinic, the doctors are very adamant. The doctors, the nurse practitioners, or the physician assistants, they're very adamant about helping the patients. And sometimes when we approach therapy, we have to mix both ventilation to reach the appropriate AHI, normalize the AHI, and comfort. It always has to be mixed. Why do you need to meet both ventilation and comfort? It's because we need the patient to be compliant. Therapy is based not on one night, 2 nights. This is a chronic disease. So you have to think into years of usage. And if the patient is immediately uncomfortable, right, they will not even want to do a second night, even a third night, even after you are able to titrate them perfectly. Okay? When they wake up, they feel good. Oh, wow. However, my nose hurt. Or there's a nasal bridge pain, right? Or my teeth feels tight. I don't know why, but it's uncomfortable. And it goes as far as, oh, I don't like the marks on my face. But you had to tighten it because you have high pressure. So you had to tighten the mask. And on that note, there is a disconnect between the clinic and the sleep lab when that happens. And that's why sometimes it's not helpful when the patients get exposed to the masks before the titration because the techs need that initial education for the patients. That's just my perspective, my opinion. Why? Because we need the patient to be compliant the night of the titration because the patient's therapy will be based on a prescription, not outside of the lab, in the lab. That's the only opportunity for the patient to have an evidence-based pressure setting. Some patients are not seen in the sleep lab and are given a dose of pressure. For example, you get an OSA patient. What do you do with that patient? You give them a stop band, an Epport. Doctor reviews, analyzes. Okay, Epport, very sleepy patient. How about stop band? Ooh, very high risk for OSA. So what would the doctors do? Offer them HST, right?
Yes.
Because if the OSA risk is high, but there is no hint or signs of hypoventilation, neuromuscular disease, so COPD, any other comorbidities, right? If the patient appears to be purely OSA, they will not go through a PSG. They will go through HST. And why is that? Why? One answer, because of insurance. Insurance dictates what happens to the patient. If I was the doctor, I can't justify a PSG, but that will be questioned and that will not be paid by the insurance companies. So in order for the patients to get into a PSG, they must exhibit or have signs of comorbidities. Anyway, going back to desensitization, now understanding the patient's concerns, whether they already have a preferred mask. I came in here, I saw Dr. Jeremy, told me to wear a nasal mask is perfect, it's smaller. I don't like the big mask, okay? Now you're already battling a negative, you're battling a stigma. The patients already don't want to touch full face, okay? Because they have had a different education ahead of you. And that's why it takes even harder for us to reroute them, because that's why we have to find ways in mitigating those issues, because we want to desensitize the patient even before they start to use the machine. One is we have to educate them that the purpose of that study is to find the pressure. This is giving somebody the correct dosage, right? Because this is a prescribed item. It's not an over-the-counter. This is what happens to patients with OSA, and then they're getting an APAP from 4 to 20. You don't know what pressure fixes the patient's majority of their apnea. They can have some apnea, of course. Some patients have high level of events during sleep onset. So some patients have high sleep onset events, which makes it very difficult if they start their pressure at 4. And so for those patients that are on APAP and they start at 4, whereas they actually have higher AHI at the beginning of their study, at the beginning of the night, those are the patients that end up pulling off the mask because they don't feel drowning. That they're drowning, they feel like they're suffocating because they are not getting enough pressurized air. These patients need to be on a higher pressure. Some of these patients end up with what they call empirical pressure. Okay, some patients are given APAP because they just did an HST and then they went on an APAP. The problem is that it can work for sure, but they need to be titrated still because the dosage or the right pressure for a patient is not as wide as 4 to 20. And the problem is that some providers or some sleep providers depend on the algorithm of the machine versus actually minimizing the chances of having time or moments in their therapy throughout the night where they are untreated. And typically that's at the beginning of the night or while they are in REM when they require higher pressure settings. The point in desensitization is for us to help the patient mitigate any of the barriers into their therapy. But the problem is that it's not just therapy, but just to even initiate our titration. Okay, so it's very important to understand what are the patient barriers. So barriers such as misinformation or different expectation. We mentioned earlier, they were told that only full face mask or nasal mask, and some are even offered pillows. Oh, use pillows. They can work with pillows. But as a clinician, we have a bit more understanding as far as maybe that's not the best right now. Comfort is probably key ingredient when it comes to the long-term compliance of the patient. However, when the patient is in the lab at night, we have a higher priority of getting the patient's optimized pressure. Okay, that is the key for us. When we titrate, what is our purpose? Our purpose is to find that optimal pressure. We need to find the optimal pressure for that patient so that we can minimize their apnea events. So minimizing the apnea means that we need to focus on finding that best pressure regardless of the mask. Now, it's also important for us techs to understand that full face is not the go-to mask. Based on clinical evidence, nasal mask is even more superior when it comes to titration. Okay? For one, we have discussed before that when you use a full face mask, the strap that goes at the bottom pulls the jaw backwards. When you pull this backwards, at the back of the throat, the airway becomes smaller. When the airway becomes smaller, you require higher pressure to open that up, to splint it open. So if you look at it from the mechanism or the dynamics of the pressure versus the patient's airway closure, yeah, full face doesn't really help when it comes to titrating, but it can help with maybe the mouth leaks. Now, let's go to mouth leaks. Oh, patients can tell you, I breathe through my mouth. Or maybe I don't breathe through my mouth, but then they end up breathing through their mouth. Now, the problem here is it depends. Some patients, they develop that compensatory mechanism to breathe through their mouth because of their apneas. So if they have apnea, they can't breathe. They tend to open their mouth to breathe, right? To just wake up and they feel themselves breathing through their mouth. And so if that happens night after night, months after months, years after years, what do you think will be embedded in the patient's memory is that, oh, I breathe through my mouth. And so when we hear that, you can't just immediately say, oh, you're a full face patient, right? So meaning to say, when a patient tells you, I only breathe through my mouth, accept it, but don't depend on it, okay? Breathing through the nose is the normal way of breathing. It's a compensatory mechanism to just breathe through the mouth. Some patients have to breathe through their mouth because they have their Malampati score is pretty high. Maybe it's 4, right? So Malampati is even while they're awake, they have airway closure simply because one, their airway is open and they have large tongue or macroglossus, right? For example, Down syndrome patients. And some other patients, they are just maybe they're morbidly obese or obese with enlargement they have enlargement of the tongue, and then the upper airway is inflamed, right? Because of many other reasons, maybe from smoking or from a disease, etc. But their airway is already small as it is. Okay, so these patients, yeah, they will breathe through their mouth, but technically that's their immediate and everyday way of breathing. Okay, however, when we apply the PAP therapy, know that you are opening the airway at the back of the throat. So since you're adding flow and pressure to the nose, that pressure might be enough. If you find that pressure, it will open up the back of the throat, which then they don't need to open their mouth. So technically, you have the capability to help this patient relearn the way to properly breathe, which is through the nose. And why is it important to breathe through the nose? Well, for one, we humidify the air, right? The nose humidifies the air. Whereas when you breathe through your mouth, you dry the air, right? So when the patient experiences dry throat, they will wake up because one, they will start to cough. I cough even right now. I'm on my ASV. My initial pressure is between 12 and 13. But it's when I first put my mask on and I didn't preheat my PAP machine where I can already have moisture in the air and I just put it on and it's still cold, I start to cough at the beginning of the night. Okay, because the flow of air dries the mucous membranes and that will make the person or the patient cough. Okay, so one key feature that we have to understand is regardless of your patient, try to preheat your humidifier. Okay, that will help you desensitize the patient. So we're not just talking about the PAP therapy, the PAP pressure per se, the type of mask. Also talk about the humidification. Humidification plays a big role in desensitizing patients, whether they're in the sleep lab or they're at home. When you educate your patients, you have to also give importance to the proper humidification. So humidification is also a double-edged sword. It can go where it's too dry still, or it can go too wet. When it's too wet, what is that called?
Rain out.
Yes, rain out. So that will be on the RPSGT exam. For sure, it'll come out. So rain out is when you have accumulation of water vapors or you have condensation in the tubing. I usually wake up when that happens to me because you'll hear the noise, okay? You'll hear a noise in the tubing. So if you have rain out, the patients will hear that every time they breathe. It creates that vibrating sound. And since the machine is attached to the patient and is connected to the patient in a sense that they're wearing a mask and then the strap. There's a difference between the noise level of what you hear as a tech versus how the patient hears that noise. Okay, there's a radiated noise, but there's also a direct noise that you can hear. Okay, it's louder for the patients. Going back to desensitization, it's as important on choosing the right, especially to begin the therapy, right? You can accommodate the patient's request, okay? But always make sure that you offer a couple of options. Some labs differ from the other labs. Some labs, it's a protocol for when a patient is in for a split night or for a titration night, that they must try at least 2 or 3 different masks. If you go beyond 3 masks, it's too much. Sometimes for me, I have 2 options and you should stick to that. Sometimes offering the patients too many options will confuse them. And then they'll expect something else. They'll say, I tried 4 masks, so let's try all 4. Oh, that just messes up your titration night, right? Because then the patient has an expectation. If they ever wake up, they're going to ask you for another mask, the other type of mask. Okay, but you're in the middle of trying to find the optimal pressure. So you need a continuation of sleep versus switching masks. Every time you switch a mask, you stop your momentum, you stop the patient's momentum, you increase the wake after sleep onset for one, right? But you also stop the titration portion to find the correct pressure. It's a momentum because the goal is for the patient to experience a few cycles of sleep, meaning you wanted the patient experience PAP therapy and actually into non-REM and REM sleep. So that's one of the key elements that we need to also try to protect for patients to experience as many cycles of sleep as much as possible. Many of these patients, especially if they have severe apnea, they will not go through deep or proper sleep stages. So many severe patients, you will not see them deep sleep or REM sleep. Many of these patients only hover between wake N1, sometimes N2, then back to wake N1 all night long. So when they get into PAP therapy, they can go further, deeper into N3, which, as we all know, N3 is what? That's your restorative sleep for adults, and that's for growth with pediatric populations. But anyway, you want them to go deeper into sleep, into N3 sleep, then have a REM cycle. And REM is really where we try to optimize the therapy, right? Optimal titration is when you have the patient in REM supine for at least how many minutes? Yeah, but for exam purposes, make
15,
15.
yeah.
All right. So now, the point there is the continuation. If, for example, the patient already had gone through one whole cycle from N1 all the way to REM, then got back out, back into N1, N2, right? N2 is when they'll spend most of the night. At least 45 to 55% of people sleep, right? So anyway, there is a momentum to get into the next cycle of non-REM and REM sleep. But if you keep interrupting that, it will delay the other cycles. Does that make sense? So it has an impact on that entire patient's experience or your entire titration. Okay? So you reduce the number of interruptions, whether you need to change a mask or you troubleshoot the electrodes, etc. Which takes me to a side point here. When you end up with an artifact and you're like halfway through your titration, and there's an artifact on C3 to A2, right? C3 to A, there's an artifact. You don't necessarily have to go in the patient's room. Why? If you already placed C4 to A, then you can stick to that. Because what is the recommended montage anyway? Do you require C3, F3, F4, O1, O2? Is that the requirement? Yes or no? No. So the requirement or recommendation per AASM is that you have one side, right? You have a C4 to M1 or an F4 to M1 and then O1 to M2. But you need contra ear, right? Contra ear montage. But you only are required to have half. You don't need the entire C3, C4, F3, F4. You attach that so you can minimize going to the patient's room to intervene and troubleshoot. Because once you get into the patient's room, you fix the patient's electrodes, you are already affecting the momentum of that patient's sleep pattern, okay, for their next cycle, etc. So that increases WASO, wake after sleep onset, and then you also will affect maybe the patient could have gone through 3 or 4 cycles of REM, but because of your interruption, then you just cause the patient to have 2 cycles of REM, which is not as optimal. Anyway, let me stop there right now. Any questions? Desensitization? All right. So let's go back now to get to the desensitization portion of this. Right? To desensitize the patient is for them to break through their barriers. One is pressure or the flow or the discomfort of using a mask or their expectation of using a particular mask. How do you mitigate that? One is by educating the patient and by reiterating and giving them realistic expectations. Okay. Sometimes it's good to make the patients feel comfortable. It is actually a mandatory thing for us. If the patients become uncomfortable with us, then they might not even do the sleep study, right? So you make the patients feel comfortable, but not to a point that you will compromise your titration. Does that make sense? So how you educate the patient is that, oh, okay, you're willing to maybe meet them halfway. Oh, you're told that a nasal pillow is best for you. Try the nasal pillow, but this time you have pressure. So that you have to give the patient the experience and allow for them to use a nasal pillow mask and put them at the pressure of 4. However, when you also apply a mask for your titration and you stay at a pressure of 4 when you are fitting them with a mask, what do you think happens when you increase pressure and you reach a pressure of 10? Do you think that adjustment of the mask is still able to hold that patient's head or hold that patient's therapy without the mask coming off, causing leak, etc.? And the answer is no. This is one of the techniques that's important that I want to reiterate. When your patients are comfortable with the pressure of 4 while you are desensitizing them before your titration or before your split night, try to increase pressure. Give them 5 minutes. Okay, yeah, this is okay. You go back. After that, you increase pressure, 1 or 2, and then let them feel it, right? 2 to 5 minutes, and then you go back. If you can get the patient tolerate the pressure up to 10 cmH2O, you're doing good. But maybe you got them up to 7 centimeters of water pressure, and they say, oh no, that's already too high. That's okay, but at least you're able to increase the pressure and make the proper adjustments to the mask to hold that pressure without the mask leaking. Does that make sense? And the other point that I want to reiterate is that when you test the patient to desensitize them prior to the titration, you should already have the water on. You have to have the humidifier on. Okay, pre-warm it, because those few minutes of trial can make them already experience coughing and dryness of the throat. And that will not help you get the patients comfortable with that initial reaction. Okay, if I was the patient and you tell me, try this mask, I put it on, just after seconds, I start to cough because my throat is dry. That's already a bad first experience, right? So you have to have the humidifier preheated, okay, so that you can already have some moisture in that circuit. Okay, does that make sense? So we did talk about humidification, the appropriate level, okay? Now, some patients prefer a little bit more dry, some patients prefer a little bit more moist. So it's hard to gauge that at the very beginning. So you can always put it on the medium level for your humidification. And I also ask the patient if you are using, say, a climate line, right? Or what's the Respironics one? The heated tubing. Always gauge it from the medium setting. And then once the patient's using it, you can make sure you ask the patient, is that air too dry? Do you feel too dry, or is it a little bit too moist for you? Or this other point, is that air too warm? Or is that air too cold? The reason being is because if you're using a particular humidifier, you can make adjustments. You can take it off on auto mode, and then you can adjust the temperature of the air or the level of humidity that the patients can feel. Some patients like it more moist. And so if you have it on auto and they don't feel that moisture, they're like, it feels too dry, right? Or it's too cold. Then you can switch it to manual mode and increase either the temperature or the humidity setting. Does that make sense? Questions? So what machine are you using? ResMed or Philips? Oh, OmniLab. So if you're using OmniLab, that's an older machine. So it's not the DreamStation. Yeah. So the older machines, the OmniLab, yeah, you can only change the temperature of the heat plate. It's actually just a heat plate. So you put the humidifier, you slide the humidifier in, and you're controlling the temperature of that heat plate. And if you increase it higher, it makes the plate hotter, so it creates more water vapors. So it's hard to control that because it's manual. Okay, it's manual. If you use let's say a climate line where you have the automation, the climate line, for example, you can adjust it to where you can adjust the temperature of the air, but then the humidifier will adjust to create at least 80% relative humidity. Okay, that's with the automation. But with an OmniLab, the old hose, and it's not heated hose, the Dream Station, I think, has more options. So you can keep it manual, so you can separate temperature and humidity setting, or you combine it with an automatic setting and you just change the temperature of the air. So for example, it's usually set at 80 degrees Fahrenheit. And the humidity setting is typically at 80% relative humidity. So we can discuss humidity in another class because that requires a bit more discussion, okay? Because with humidity, it's a key to your desensitization. It is a key to patient comfort and long-term compliance. Now, there are variables that will affect humidity, particularly the relative humidity, because you have at least two types of humidity that we discuss in sleep, right? The relative humidity and absolute humidity. So we'll discuss this in the humidity lesson. All right. Now, to wrap this up and put it together, desensitization is not just after the patient has already been in the sleep lab. Desensitization is a knowledge and it's a skill that you can use and increase your likelihood of a more comfortable and more compliant patient and a better titration. So if you understand the key elements, particularly the humidifier portion or the humidification, it also helps with the leaks. There are clinical evidence that if you have a proper humidification, it reduces leaks. It reduces mouth leaks, for one. Okay? So always remember, preheat the humidifier before you even test the patients. You can give them at least two options, but when you give them options for mask, you have to make sure that you have already preheated the humidifier, and then you also have the opportunity for the patient to experience a higher pressure than just 4 or 5. Because eventually, if you adjust the mask and it's properly fitted, it's good to go. But as soon as you increase pressure, it starts to pop off the face. Why? Because you didn't test it on a higher pressure. So you'll find out that it becomes less challenging if you're now able to desensitize the patient with the appropriate pressure. If you have already increased as high as possible, at least up to 10 centimeters of water pressure, then you now know that the mask will hold appropriately all the way to 10 centimeters of water pressure. When you fit the patients and you're trying to desensitize them, don't just have the patient sit, have the patient lay down. Have the full experience. When you have the patient lay down, make them go to their right, adjust the mask, make sure that the leak is gone, and then later on move them to the left. If the patient gives you a pushback, so let's say the patient says, that's too uncomfortable, and you have them at a pressure of 4, only at 4, and they're already pushing back. What you can do is that you give them the mask, right? Let's say you give them the nasal mask, or a full face mask, or a pillows mask, but don't strap it on their head. Don't. Just give them the mask. Now make them hold it so they have control, keep it at the lowest pressure, and tell them to just breathe 5 times. If they can't breathe 3 times with the mask on, so when they go, they're apprehensive, they're like, I don't know if I can do this, just take your time and walk out. Just show them, put the mask like this, okay? Don't strap it and just hold it and breathe 3 times. And then take it off. And then put it again. Do that for a good 5 minutes. But leave, okay? Leave. Because they'll be less pressured, okay? And when you come back, okay, how is it? Actually, not too bad, but I'm still freaking out. Okay, that's fine. Now can you breathe like 10, 15 times? Okay? You're desensitizing the patient with how the pressure and the flow interacts with their own breathing. Because many patients are becoming apprehensive or reluctant because They feel the initial conflict of flow, right? You have a pressurized machine blowing air inwards and they're trying to exhale. That's difficult for some patients, and in fact, for many patients. But when they realize that, actually, I breathe in and out with this thing on, right? What they'll try to do is they'll try to breathe out through their mouth. No, don't let them do that. Let them breathe in and out through their nose. Let them feel that they can actually breathe out with the CPAP pressure, right? So when they're able to understand that, it will click. I can breathe 10 times with this. Okay, 10 times, then take it off. But they have the control. They're holding the mask. They're not strapped. So if they freak out, they just take it off. If they're able to breathe 10, 15 times, you can leave them alone. And next thing you know, they'll hold the mask. Okay. Once they're able to hold the mask, you can strap it on. Once they strap it on, make them lay down. Okay. A few steps. Okay. And so while you're doing this, you might be thinking, that's going to take a long time. How about my other patient? That's your chance to either go back, leave the patient for a good 5 minutes, go to your other patient, take care of their forms, educate them, show them where to go to use the restroom, come back, check with the other patient, do the next step, ask them to make them breathe longer than 3 to 5 breaths. And then once you're done with that, go back to the other patient, okay? Or go to your tech room, start to input the information. So it's about using your time more wisely, okay? You're not just sitting there with the patient and looking at them like, come on. So on that note, there's more to desensitization, but you have to first allow the patient to express their concerns, their issues, their pushbacks, or maybe they're just misinformed, or maybe they want something and they want you to allow them to get that first. Like, I just want a nasal or a nasal pillow. Okay, that's fine. But I have this for you. Is this what you like? They say yes. Okay. Now, in the middle of the night, you have to give them the realistic scenario. Your mouth might leak, etc. So I need to have the capability to maximize your night. And so I need for you to test this other mask out in case we need it. That's the point. Okay, in case we need it. Don't tell them that I'm gonna switch you out anyway, regardless. So in case we need it, I need you to also test this other mask. And sometimes patients will realize that, oh, actually this one's better. I've had patients like that where they came in and they're so like focused on, I'm only going to use this small mask, this pillows mask. I don't like that big bulky mask. But then when they get to test it out, because I let them try 3 different masks, they're actually more comfortable with a bigger mask. And this is probably one of my last points before we stop. One of the issues with pillows is that it presses on the, right? When you tighten the pillow mask, it pushes right here. And there's no other area that can put pressure, but mainly on the nose. So they can wake up and feel this so sore, like they've been punched through the nose. And the reason why I know that is because that's how I felt when I switched to a nasal pillows mask. I woke up the next day. It was comfortable at the beginning, but I fell asleep. And when I woke up, I felt like somebody punched me. And that's because nobody's used to using a pillows mask until you gain experience with it. Then you will adjust. If whatever mask you're using or whatever the patient's mask is, they'll adjust to it. Whether it's a little discomfort, just not pain. If they say it's painful, different story. Then don't use that mask. But anyway, my point here is that if they are so sure they only use full pillows mask, and then they get to experience it, they'll actually be surprised because the pressure might feel less, right? And if they use a full face mask, which has a bigger dead space, and so the flow doesn't feel as high and the pressure doesn't feel as high, even if you are using the same pressure, is because of that buffer, that dead space. It lessens the jetting effect, Jetting, jetting effect. When you use a pillows mask, it has that jetting effect. It shoots the air, feels like too strongly because of the smaller dead space and that the air pressure can only go to that area. Whereas if you have a full face mask, that the pressure coming from the tubing, it dissipates before it reaches the patient's nose. Does that make sense? Okay. So when the patients feel that, full face actually feels more comfortable than the small one. It's because of that jetting effect. Okay. Now, I said last, but this is the last one because this is technical consideration. When you are using different types of masks, you have to make sure that when you switch masks, you switch the setting. Okay? Because if, say for instance, you use a nasal pillows mask and then you switch to a full face mask without changing the setting in your OmniLab or your VPAP2X machine, the pressure is not going to be the same at the end of the mask. So you have to make sure you coordinate the setting to the actual the patient is using. Otherwise, you're not using the same pressure. You might be titrating the patient at 10 centimeters of water pressure, but the pressure that goes to the patient's nose is only 8 or high, right? So you can either go lower or it's higher. Okay? Sorry about that. My mouth is drying, all this talking. Make sure that your setting is correct so that you will optimize the patient's therapy, but you'll also have the accurate therapy pressure. Okay? Don't forget that. When you change mask, change the setting. All right. There's a couple other things I wanted to add, but let me pause here right now. Any questions?
None so far, Kim.
None? Okay, making sense?
Yeah,
May
yes.
question ako.
Yes, go for it. Okay.
My last question. What if the patient is suffering
Like claustrophobic, right?
what if the
Yeah.
patient is claustrophobic and then really can't tolerate any kind of mask? Are there any remedies or medication that you can give, or your last resort is to really cancel or not push through with the therapeutic po?
Yeah. So you have to give them a tracheostomy. No, I'm just kidding.
Performance surgery right away.
Tracheostomy.
Plastic, sir. I thought you must intubate them first.
No, so claustrophobic patients actually very common, and some are true, some are not. Okay, that's why one, if I can help it, I will not start testing them with a pillows mask. Don't, because of that jetting effect that adds to that claustrophobic feeling. Patients will think that, claustrophobia, you feel like you're getting suffocated, things are closing in. But then don't use a mask that will cover the eyes. You can use a full face mask and it's just below the nose. So you guys are familiar with the other mask, the F30 or F40, right?
Is that the hybrid one, sir?
Yes, so it looks like a hybrid. So let me share my screen. Because that's a good point, because that's very common issue. Patients will say, I'm claustrophobic. So if you look here, they can see. However, this is a full face mask. Okay? So the issue is if they feel like they're closing in. Now, the older mask, if you use, can you see my screen? Okay. Now, look at that mask versus this mask. See the difference? This will only exacerbate what they're thinking. One is because you're closing in on their eyes. Okay? So if the patient says, I'm claustrophobic, don't put any mask that covers their eyes or that they have a bar in the middle. Don't use that kind of mask. Give them something, even a Quattro FX, which is an old mask. Well, this is okay. But one of the better masks that I found really good, if you have them, is the Dreamwear. You guys have it there? The Dreamwear full face? Check it out. It's not only less bulky, because the other masks, even though they are below the eyes, they're bulky like this. This one is very shallow. So it's close to the face, right? And talk to the patient. Talk to the patient. Let them talk. So they can feel the pressure. And then when they're able to talk, that means they can breathe. You got that point? So it reduces their apprehension. So that helps with claustrophobia. And other masks that you can consider, of course, are some are nasal pillow, but this one is, there are two kinds. Nasal pillow is when you have the prong go inside the nares. There are nasal masks that look like pillows like this, but they have a big hole. They actually cover and they just sit outside of the nares. It doesn't go inside. Okay? Those kinds of masks helps because you're able to titrate, you'll get the pressure, but then they don't feel like their nose is being closed up. Okay? So my answer to your question is that one, don't strap the mask. Put at the lowest pressure. Start with a mask like this that sits below the eyes, below the nose. Nothing's blocking their view. Okay? If they get to feel it and they can breathe in and out with it, okay, then they'll get to understand. However, if your patient just said, no way, or they start to feel panicky, right? Okay, take some deep breaths, get some water, let them drink, and don't move forward. Call the doctor and said this patient's not going to tolerate the CPAP. Because your only other option is to put them on bilevel. So you can put them on bilevel. The problem is with bilevel, you increase the initial pressure, right? If they're already claustrophobic with a pressure of 4, how much more if you start the pressure at 8? Because it's 8 over 4. But if you can get them to test out a bilevel, right, they will feel that pressure drop on exhalation. So that is one possible avenue that you can experiment to see if that particular patient will tolerate a bilevel titration versus CPAP. Now, there is, of course, an additional consideration when you do that because insurance. If the patient is cleared for a CPAP titration, it doesn't mean they're clear for level immediately. That has to be annotated that the patient is unable to tolerate CPAP. And the only way you can do that is if you actually include that in the study. So when you're just testing them out, you don't have the electrodes yet, you didn't do lights out, you haven't recorded the patient, and they're already saying, no, I can't do this. And you switch directly to bilevel, you're going to have a hard time justifying the patient starting their titration on bilevel. What happens then, that insurance company will deny that sleep study to be paid, and your doctor will have to write a justification. Right? The doctor has to write a letter of medical necessity. Okay? So I know that kind of complicated things, but that's the truth. And in fact, that scenario can come up in the exam. The exam also covers insurance. All right. Does that help? Just don't do the tracheostomy. I know you guys have experiences, and I hope I added a bit more into this, different scenarios to help you with your, not just with your study, but also your practice. All right. So, well, without any other questions, I hope you get some rest or enjoy your shift. Thank you.